Okay, all right. Thank you very much again for waiting. My name is Suvir Venkataraman, and I am your host for this evening's webinar. And so the topic we're going to be discussing is egg freezing. And I'd like to introduce you, well, to a sort of slightly reduced panel this evening. We have joining us Dr. Geetha Venkat, who's the director of Harley Street Fertility Clinic. Unfortunately, Ms. Sam Knight, our lab manager, couldn't make it owing to personal issues with the tube strike, and I'm shown in the corner. So the agenda for this evening we'll discuss what's called the fertility checkup that will be discussed by Dr. Venkat, and then we'll cover the egg freezing treatment and the summary of the pathway, i.e. the practical side of it. The event will be recorded and uploaded on our website in due course for you to rewatch if you missed something or forget something. We will have a Q&A at the end, so you can raise your hand or submit questions via the Q&A function on Zoom. And I noticed actually one of our attendees has their hand up at the moment. If there is something, please just pop it on the chat, or do you wish to speak? If you wish to speak, I can allow you to talk, so just keep your hand up, or if you want to take it down, please do. If you want to stay anonymous, that's absolutely fine. You don't have to say your name, and your camera can remain off. So I'm just going to check if this person has something to say. Hello, do you have anything you wish to say? No, I think...
Mute, she's on mute.
Yes, there we go. Yeah, hi, do you have anything you wish to share? There's something come through on the chat. Oh, please speak louder, I can't hear you. Okay, I'll do my best. If you maybe turn your volume up, and I will see if I can turn my microphone volume up. Thank you very much. Sorry about that. Okay, great. So without further ado, I'm going to hand over to Dr. Venkat to cover the checkup. Thank you.
Thank you, Suvir. Good evening, ladies and gentlemen. Thank you for joining us on this webinar on this evening. I know with this tube strike and everything, it's going to be a difficult evening, but if you're all working from home today, it's ideal to listen to something which will be very useful for you. So first of all, I'll go through the basics of fertility. Everyone should have a fertility checkup. I think the government has got a pap smear test for everybody as an important checkup for women. Fertility checkup should be a routine in all the countries so that people are aware of their fertility status. So that is very important. And now a lot of couples are coming for fertility checkup even before they are starting to try, or even before they think of the family. They want to plan their life. So they want to know whether to give priority to this aspect in their life or something else first and then come to start the family, which is a good idea. So now let's see what are the things we do in fertility checkup. As you know, to make a baby, we need sperm and egg. So in the female, we check anything relevant to the egg as well as the bag which is going to carry the baby, that is the uterus. So to achieve a pregnancy, as you see the egg and the sperm. And we also do the blood test to check the physiological things in the body to assess the hormone profile and the ovarian reserve. And the third point is about the uterus, where the embryo implants, that is the endometrial development and implantation. Next slide, please, Suvir. Okay, so what are the tests we do? We do an ultrasound scan for the female and blood test also at the same time to test various hormones. I will go through the details in a minute. This scan is a vaginal scan. A lot of times women get confused between vaginal scan and abdominal scan. Abdominal scan is used for studying other structures in the abdomen, but the uterus and ovaries are pelvic organs. We call them pelvic organs because they are very much deep inside the pelvis. And earlier days, or say in 1960s and 70s and 80s, the vaginal scan was not invented at that time. Therefore, all the scans were performed abdominally, and it was like a hazy vision of the uterus and ovaries. Now in 90s, we got the vaginal scan. This gives a close view of the uterus and ovaries and better assessment. That is why performing a vaginal scan is important for any checkup, female fertility checkup. So we always perform an internal scan. A lot of women, we take it as a routine, so we don't sometimes mention it, but women are not aware. That's why I thought it's important to mention that is going to be a vaginal scan. And in the scan, we look at the uterus as we saw in the first picture and see if there is any polyp inside the cavity or fibroid inside the cavity again, which can interfere with getting pregnant. Next step is to check the bloods for different hormones relating to fertility. This we are checking the physiology. So first we check the anatomy in the scan and then physiology by the blood test. So the hormones we study include anti-Mullerian hormone, that is the AMH, as you can see, and that is an indicator of ovarian reserve. We studied the egg number in the scan as well. So in the scan, we look at the uterus and the ovaries. We look at the number of eggs. That's very important. And in the blood test, we do the AMH, that is for the ovarian reserve. Other hormones we check are FSH, LH, and estrogen, which are indicative of ovarian function and indirectly quality of the eggs. That is very important because young women, the quality should be good, but especially in women over 40, the FSH will tell us whether the ovaries are working well and the quality is good for their age or not. And the other hormones include thyroid function test, free T4 and TSH, prolactin and vitamin D. All these things are related to fertility indirectly. They affect ovulation, and some of the deficiency of thyroid hormone or vitamin D can cause miscarriage. Therefore, it is important for them to know about this and correct this hormonal problem so that before they start trying, we optimize the body to prepare for the pregnancy. And all the hormones which are checked are related here in this graph. You can see related to the different days of the cycle. Therefore, we must know the best time to perform this scan and blood test or between the 2nd and 5th day of the period. Because the hormones, as you can see here in this picture, it's the lowest in the first 5 days. After that, you can see that some of them starts going up, some of them is like this parallel. And if we check somewhere here and it may be high and you think that, oh, it is high because your interpretation may be different if you do it on different days of the cycle. And also it depends on which hormone you are testing. The FSH, LH and estradiol, we say the best time to do it is between day 2 to day 5. And if somebody is checking for ovulation, you might have heard from your GP day 21. We call it mid-luteal progesterone. That is actually 1 week after ovulation. If somebody has got long cycle, it will be a little bit later. So we have to remember that. Next slide, please, Suvir. So when to get a checkup? So ideally, like I said, if somebody wants to plan the life so they can do it, say, in their early 30s or late 20s, and they can have a checkup to plan their life, or once they have a relationship and they are planning their life together, again, it's better to know, look, do you want to buy a property, settle down first, or start your family, which is important for you. Again, if there is some fertility issue, you don't want to delay this anymore. Therefore, you will give priority to this fertility matter. So ideally, it should be under 35. Over 35, sometimes people are having fertility checkup in case they start a relationship later, or if they are not able to find a suitable partner, they want to know whether to do something about it now or is it okay to wait. That is the reason for doing it a little bit later. Okay. Or if you have a family history of premature ovarian failure, one should definitely check. Again, as it is written here, you can say FSH alone is not enough. This is a very good statement, because sometimes such patients have got, I have had the same patients whose mothers have had early menopause, and they go to the GP and say, look, my mother had menopause early, should I do any test because I want to protect my fertility? The GPs have told them to do FSH, and FSH is normal. So the GP has gone and told her, look, you don't have to worry about it. You just lead a normal life. Everything is normal now. Then she found that after 1 year, she stopped having periods, and then she came for a checkup to our clinic. Then we did the AMH. Then we realized that she has run out of eggs. It was too late by that time. That's why she stopped having periods. So testing FSH alone will not indicate whether your ovarian status, ovarian reserve is good or not. Therefore, AMH is one of the key hormones we should check. And if the AMH level is less than 5, we know that it is low ovarian reserve. Okay. Then if somebody's ovarian reserve is borderline or even in the normal range, and if you want to delay starting the family, I won't say it's all normal, you go and you don't have to worry about it. We can't say that, because sometimes the hormone AMH can start going down slowly, or women will start losing their eggs. Indirectly, they start losing their eggs at a rapid rate. Under these circumstances, their ovarian reserve will drop rapidly, and the AMH will start going down rather quickly. That is why it's important to keep an eye or keep monitoring the AMH. And we say that keep checking the AMH every 6 months to know where you are in that situation. Supposing the AMH is maintaining good level, it is fine. Or if starts going down, then we know that it is time to act. And supposing you are not in a relationship and not ready to start a family, then we advise women to consider egg freezing, especially at that stage. Like, I always say it is amber light flashing, because if everything is normal, it's according to traffic light system, we know it is green. Red is like, oh no, you have no time to lose. That is, we don't want to go into the red zone. That's why it's amber. And at that stage, you should do something. That is when things are reasonable, start considering egg freezing as a plan B or backup arrangements. Next slide, please, Suvir. And now we are going to talk about egg freezing, and we'll go through the procedures. I'm going to hand over to Suvir.
Thank you very much for that background. It was really helpful to know, what people should look at before they look at egg freezing, because how would you know that egg freezing is the right thing for you? So, I think education and awareness it can't be stressed enough about knowing your fertility, because, in school, we all get told about sex education and how to prevent a pregnancy, but often we're not educated about, our fertile window. So then, once you're looking at egg freezing as a treatment option, the treatment itself is relatively straightforward these days. It's a well-developed treatment, and it works well, and it's fairly quick. So it takes about 2.5 weeks. It does, we do need to know about your fertility. So we do need a checkup or an assessment first, so that we can look at, the right doses for you and so on. And then we'll freeze the eggs. The things to bear in mind are that once we freeze eggs, they have a shell or an outer wall, similar to a chicken's egg, that does harden once you freeze them, thaw them. So when we do, when you come back to use these eggs, you will need to inject them by a process called ICSI, which we normally use when the sperm quality is not so great. But in this case, because the eggs have been frozen, the shell will be a bit harder, so sperm won't be able to fertilize it without being helped along a little bit. And then if we work backwards to say, you want not a guarantee, but a very, very good chance of achieving a pregnancy with our current success rates, if we run all the numbers backwards, a good target number of eggs to try and freeze is about 30. And this might sound like a lot, actually, but at each stage, what happens is you lose some eggs, and there's quite a few stages to get through. So this is a good target number, and it might require more than one round of egg freezing to sort of get there or close. So then if we look at the details of this, egg freezing, as Dr. Venkat mentioned, it should really be a plan B, because once you take the eggs out, you're going to use them, you fertilize them, create embryos, and that's it. So we always advise patients to try naturally first when they're ready to start a family. And there is no guarantee, unfortunately. Our success rates have come a long way, and I'll talk about that in a moment. But there is unfortunately no guarantee with frozen eggs. Infertility or fertility treatment is not a complete science as of yet. We don't have 100% pregnancy rates. So there is always a bit of an unknown, and so you might not always achieve a pregnancy. Right now, as per the regulator's guidance in the UK, eggs can be frozen for up to 10 years. Parliament has, I believe, passed a bill, but it hasn't become law yet, to actually increase that to 55 years, which at present you can only store them for 55 years for medical reasons. But I believe, fairly soon we should see that come into law, so that anyone choosing to freeze their eggs for whatever reason it might be can store them for up to 55 years. And we often get the question from patients, will the eggs be all right? Is it going to affect their quality? The eggs are fine. Technically, they can be kept for a few hundred years. And as long as we've frozen eggs, we've never seen any degradation. We've done lots of animal models and studies, and there's no degradation in the tissue. It doesn't matter how long you keep them in liquid nitrogen. And the other thing I alluded to earlier is the success rate. So egg freezing, if you talk to us in sort of the early 2000s, it wasn't a great option. And that's why it was only really considered in cases of chemotherapy or something similar, where your fertility is going to be rendered, very poor by some other treatment. That's when egg freezing was considered. It wasn't really done for social reasons, because there was only about 30% survival rate. So if we froze 10 eggs, only about 3 of them would survive, and they weren't that great. But there was a new technique that was introduced in the embryology lab a little while ago, somewhere in sort of middle of the last decade now, around 2014, 15, thereabouts. It's a technique known as vitrification, whereby the eggs are frozen very rapidly, and they enter what's called a sort of glass-like state, which is why it's called vitrification. It means literally in glass. And this technique is really good because we get a survival rate of over 90%. So if we freeze 10 eggs, 9 of them will survive. And we get really good results afterwards. So once we've thawed the eggs, if we have 9 of them survive, they're, in terms of quality, they're fairly comparable to fresh eggs. So it's just like we had 9 fresh eggs. So it means that egg freezing is a very good option now for people who want to extend their fertile window. So life, gets in the way, or careers take longer, or university or whatever it is, education takes longer. So we can now, stretch that rubber band that is the fertile window to longer, because the most important sort of factor in achieving a pregnancy is the quality of the eggs. And one of the big, indicators about the quality is the age of the woman when the eggs were collected and then used or frozen. So if we were to collect eggs from a 30-year-old lady, and then she came back at the age of 50, her chances of success with those eggs will be fairly similar, not quite, but fairly similar to her having treatment at the age of 30. So it's a really good option if you look at it from that standpoint. And then a bit of sort of practical aspects of, what this might look like if you were to actually go through the treatment. I'm just going to grab. pointer here. So we start with an initial consultation because we think it's important to talk to our patients first to understand their history, make sure there's no family history of, sort of premature menopause or other conditions we should be aware of. Then we arrange the relevant investigations and, as Dr. Venkat mentioned, as a part of the checkup. And then we arrange a follow-up discussion with the same doctor so that you can talk through the results, make sure you understand them. And then we'll give you our advice on treatment. So if we're going to look at egg freezing, that's what we would tell you. We would tell you whether it would take 1 or 2 or 3 cycles potentially to achieve that target number of about 30 eggs. And then if you decide to go ahead, we'll arrange a nurse consultation where the nurses will talk you through the practical aspects of treatment. And then sort of, before this will all happen before a period. And then when your next period sort of arrives, you'll start ovarian stimulation. It takes about 10 to 12 days. And yes, you do have daily injections, but they are quite straightforward. And, we'll teach you how to do them. And they're not very painful or anything. So it's nothing to worry about. And during those during that period of ovarian stimulation, we're making your follicles grow. So we keep an eye on how you're responding to the medicines, and we adjust the doses. We optimize the doses to get the best response from your ovaries. So we monitor you with regular sort of scans and blood tests during that period. So you will come to the clinic a few times. It's not daily, but it is a few times. Then once your follicles reach a good size, we give you a final set of injections that triggers, essentially it sort of triggers ovulation. It makes the eggs sort of mature and they get released. And then we time that very precisely so that we can collect the eggs in an egg collection procedure. It's what we consider a minor procedure. There's no, we're not opening you up. There's no major surgery. It's done essentially with a long needle through the vagina. And you can see on this little diagram that is a cartoon showing the needle puncturing each follicle, and then we collect the egg that's in each follicle. Then we take those eggs, they come in a nice bit of bubble wrap or cumulus cells that surround the egg. We remove that from the eggs, and then we put them in essentially similar to an antifreeze solution. And then we very, very quickly cool them down to the temperature of liquid nitrogen. And that's the process of vitrification. And then we keep them safely in storage for, like I said, up to 10 years. And the eggs, they're held in liquid nitrogen tanks at the clinic that are monitored and alarmed. And if something, if the temperature rises or there's an issue, all our lab get an alert and get called out at whatever time of day it might be. So in terms of time frame, the checkup itself, it's only 1 visit to the clinic and it takes essentially a week or so. The treatment, starting with a period, it takes about 10 or 12 days to make the follicles grow, and then a couple of days later we do the egg collection. So it's about 2 weeks, but we do prime you, so we give you some medicines before you start to try and improve your response, and that takes about another half a week or so. So it takes about 2.5 weeks really from start to finish. So it's a nice sort of easy and quick and good treatment option for a lot of patients who are looking at sort of preserving their fertility for the future, for whatever reason that might be. I haven't missed anything else, and I'm going to just erase all my scribblings on here. And so I'd like to thank all my colleagues who work at the clinic, because without their work, we wouldn't be possible to share this information with you. I'd like to thank Dr. Venkat for her introduction. And now we'll open it up to a question and answer session. So I try and erase some more of my scribblings. We do have a couple of questions already in the chat function. So I will take those in turn. The first question is, what is the percentage that will defrost and survive? What's better, freezing eggs or embryos? Dr. Venkat, if you wouldn't mind answering this question, please.
Yes, okay. We have, both advantages and disadvantages for both sides now. So let's take egg freezing. the chance of survival after thawing the eggs is somewhere around 85 to 90%. Like Suvir explained in his talk very clearly, if we take out 10 eggs, usually 8 to 9 of them will survive, which is good. That is because of the new vitrification process. Previously, we were freezing the eggs by slow technique. With that, the success rate of thawing the eggs was only 40%, but with the new technique, it is about 85 to 90%, which is much better. So we have good, reasonable success with that. But if you go to the embryo freezing, the success rate with that, or success rate of thawing the embryos, is something like 96 to 98%, which is, of course, compared to the eggs, it's much better. And that is why people say embryo freezing is always better compared to the egg freezing, because when you take out the eggs, you lose some eggs, whereas you don't lose the embryos so much. We lose very rarely have the embryo not surviving. That is why people prefer to freeze embryos. However, if we have some women in the situation where they don't have a partner and they haven't met Mr. Right yet, and they can't start the family at this stage, then they have to freeze the eggs. Well, then if they freeze the eggs, later on they can use their eggs with anybody they are with. Otherwise, if somebody has a partner now, they can freeze them as embryos. That is, once the egg is fertilized with the sperm, it is called embryo, and we can freeze the embryos. However, if the relationship turns sour or something goes wrong and they have a new partner, then they won't be able to use the embryos. Whereas if it is eggs, they can use with any sperm. It gives you flexibility. That is the advantage of egg freezing, but disadvantage is slightly lower chance of success with thawing. That's how it is different.
Thank you very much. So I hope that explains, there's not a one size fits all, and there's pros and cons to both. The next question is, plus if you have a normal AMH, but only produce 4 to 5 eggs, do you keep going until you reach 30 eggs? Since this is clinical in nature, I'll leave this to you, please, Dr. Venkat.
Yeah, again, like we have some women with polycystic ovaries and high number of eggs, good ovarian reserve. But the behavior of polycystic ovaries is very unpredictable. And sometimes we start with small dose and nothing happens, and then we increase the dose. Suddenly 20 follicles start growing and 30 follicles, and when we collect eggs, then we end up collecting 40 eggs. That happens sometimes. But then we don't want this situation, because they have a very high risk of developing hyperstimulation syndrome. This is one of the risks we would like to avoid or prevent, and that is the reason we have careful and regular monitoring with ultrasound scans and blood tests to prevent this complication. This gives us an opportunity to reduce the dose of the hormones to prevent so many eggs growing and developing. That is why it is one side of the polycystic ovaries is so many eggs. But some cases, the lady is correct in asking, even if they have good ovarian reserve, they don't produce many eggs, then the situation is they have to do multiple cycles. Having said that, if the ovarian reserve is good, if somebody has not produced many eggs in the first cycle, the doctor has an opportunity to increase the dose in the second cycle and make her produce a few more eggs, so that we can reduce the number of attempts required to collect something like 25 to 30 eggs.
Yeah, I think it's, thank you. Sorry, thank you for that response. I think, I'm not sure if we sort of made it clear. Ovarian stimulation, the process of growing your follicles until we can collect eggs, is not a clear-cut science. There are protocols that we use, and the investigations that we perform help to guide your consultant in their decisions about how to stimulate the ovaries. But it's not a one size fits all, and we can have 2 women who have similar test results, but they have very different responses, even though they look quite similar. So, it's a bit of a learning process, and it is a bit of an art form. That's why it's important to have a doctor who's got plenty of experience in fertility, looking after you. But also, as Dr. Venkat just mentioned, we will learn a lot about how your ovaries respond based on that first round of stimulation. So the second round should definitely be better than the first. So hopefully they'll be able to collect more eggs. Next question is, after eggs are defrosted, is fertilization with a sperm cell in vitro or in vivo? So it's a good question. I think we assume a lot of these things when we talk to you, but sometimes they're not clear. So what will happen when you come back to use the eggs is that we'll thaw them out, so we'll take them out, and then we will take a sperm sample, and like I said, we need to inject the eggs. So it's a process known as intracytoplasmic sperm injection, or ICSI for short. And we take a single sperm cell and we inject it directly into each egg, and that's done in the laboratory, and so it's in vitro. And then we will actually, what will happen is we'll leave the eggs overnight. We'll leave the zygote, or the injected eggs overnight, and we'll see how many of them divide into embryos. So what will happen is the DNA inside will get replicated for the first time, and then the embryo will start to grow, and they start to divide, and we'll grow them for about 5 days nowadays in the lab to see that they reach a certain stage in their development called the blastocyst stage, before we either refreeze them if you want to use them later, or you want to test them, or we will transfer an embryo back and then freeze any others that remain. Does being on the contraceptive pill affect the timing of the process? For example, do you need to come off the pill before commencing the process to get the correct hormone levels and tests? Now, we see this question a lot, and I'm going to hand over to Dr. Venkat to answer.
Yes, that is a very good question, because it's a very important and practical question. We do have a lot of women on contraceptive pills before they come for the checkup, and they tell me, what should we do? So we always give them two options. One is, ideally, we would like you to stop the pill and wait for the second period. Let me explain what I told you just now. Second period, what does it mean? Why second period? As soon as you stop the pill, you will get a period. We should not do the test at that time, because you were on the pill the previous month, and it will definitely affect your hormone levels, because it's going to give you an artificial level of the hormones. Therefore, we don't like that, because it's not going to give you information about the true situation inside your body. Therefore, what we will advise you is, after stopping the pill, wait for a month, and then when you get your second period, then call us. We book your scan and blood test between the 2nd and 5th day of the period, and that is the best time to do, because you have been off the pill for a month, and then if we do the blood test and the scan, it will give us the true picture of the situation. So that's what we recommend. Having said that, there are always exceptions to the rule. What happens is, in some women who have been having irregular periods before, which they didn't know because they went on the pill, or some people with polycystic ovaries, they don't get period for 6 months. So they can't have the fertility checkup. It's going to be difficult. They will be waiting for a year even to do the the fertility test. Therefore, what we say that, if you don't get a period in a month's time, then anyway, you come because you have stopped the pill, and we will do the blood test. So that is something we advise. Third thing is, in this connection, I would like to add that if somebody is on a IUCD, that is intrauterine contraceptive device, that is the coil, what should we do? It's not like pill, it's also, should we remove it? Supposing somebody is on just copper T, that is not hormone implanted in that one. So it's hormone-free intrauterine contraceptive device. You don't need to remove it, because it's not going to interfere with the hormone test or even egg freezing cycle. Because egg freezing is we do the hormone stimulation. Because of the contraceptive device is hormone free, we don't have to remove it. However, there is another contraceptive device, intrauterine contraceptive device, which is called Mirena-S, which contains progesterone in the coil. This is the hormone impregnated coil. Therefore, the theory was previously we used to get it removed and then do the test as well as do the egg freezing. Having said that, now people have done research and they found that this is because it contains only progesterone. It doesn't interfere with the egg production or egg quality. Therefore, we don't need to take it out and we can still do the test and do the egg freezing cycle. Therefore, this you can keep it because this can be kept up to 5 years and nobody wants to take it out. And it is an expensive device also. Therefore, if you tell your GP you took it out and you go back to the GP after 3 months, they may not like it because it is quite an expensive contraceptive. It doesn't interfere with the egg freezing treatment, so you don't have to remove that. I hope it is clear to you.
Yeah, you learn something every day. I didn't know that. The next question we have, if I freeze my eggs, what's the oldest age I can use them to make an embryo and put it back inside me? Right now, as it stands, the law says you can store your eggs for up to 10 years before, and then by that time they should be used. And like I mentioned, there was an act passed it was a bill passed in Parliament, which hasn't yet become law, which is hoping to extend that to 55 years. So, the clock sort of starts from the time that you freeze the eggs. Will the eggs get damaged during the ICSI process and die at this stage before turning to embryos? So ICSI, so there are two ways to fertilize eggs. So if we ignore the fact that we're freezing them, we typically, when we do IVF, and so egg freezing is essentially the first half of an IVF cycle. So when we perform IVF, we can either fertilize the eggs by mixing the sperm and the eggs in a petri dish or petri dish, and we mix about 100,000 sperm or 50 to 100,000 sperm with a single egg, with the hope that they'll fertilize that egg naturally by themselves. They'll swim into it and fertilize it. The other way is to do ICSI, and in ICSI we take an individual sperm, and as you saw on that picture, if I can find it again, there it is. If you can see my screen, yeah. So here's the needle, and there's a sperm cell in this needle that we puncture the egg and inject the egg. We inject the sperm directly into the cytoplasm of the egg. Now, when you do IVF or ICSI, that fertilization is not 100%. So even when you mix the sperm and the eggs, only about 70% of eggs, of good quality eggs and good quality sperm, will fertilize. So if we take 10 eggs, we expect on average about 7 of them to get fertilized and to start to divide. Now, when we do ICSI, again, the fertilization rate is about the same. However, some eggs will get damaged by the ICSI process itself. So a good embryologist, again, it's important that you have experienced professionals who are looking after you. So good embryologists will have what's called an ICSI damage rate, i.e. the percentage of eggs that they damage in the ICSI process of about 5% or less. That's something that all laboratories look at. We don't let anyone sort of perform an ICSI procedure willy-nilly. It's, they have to be accredited and they have to be competent before they're allowed to handle patient samples for ICSI. And it's a delicate procedure and it requires great skill. But yeah, so about 5% of eggs can typically get damaged when injected by a good embryologist, but ICSI has a slightly better rate of fertilization. So at the end of the day, if we inject 10 eggs, again, we expect about 7 of them to get fertilized by ICSI. So it makes it comparable to IVF. Dr. Venkat, was that sort of, have I missed anything on that?
Yeah, correct. That's what it is. The standard damage rate is less than, in a good laboratory, is less than 5%. That is acceptable. And having said that, sometimes the quality of the eggs also is important. That is why we say older women should will not benefit from egg freezing so much, because if the quality is not very good, then we might lose some eggs in the ICSI process. That is the reason we recommend women to freeze their eggs in their late 20s or early 30s when you are young. But sometimes women are not aware. Not only that, this whole egg freezing has come up recently. And supposing they didn't have this opportunity at younger age and they come for freezing their eggs, we tell them, look, your egg quality may not be so good. The eggs may not survive well and also may not survive the injection well. And that is because of the age-related fertility decline, which with quantity as well as, that is the number of eggs as well as the quality, that is part of the nature.
Okay. And the next question we have is, could you please give us an idea, give us a general idea of the cost? So it's a good question. Unfortunately, egg freezing is not cheap. As a treatment cycle, if you look at any UK, or if you look at any London clinic, the cost is about £3,500 for the actual treatment cycle. And then you're looking at anywhere from £1,000 to £1,500 for medicines, potentially more if you're slightly older. So, unfortunately, women who are older or who have a lower ovarian reserve will require a higher dose of the medicines, and they are quite expensive. So for a cycle, you're looking at about £5,000. Bear in mind, you might have some preliminary, the checkup itself will cost a few hundred, and you'll typically be required to have some screening tests before. But all said and done, you're looking at about £5,000 to £5,500 for a cycle of egg freezing. And then to keep the eggs in storage, most clinics will charge about sort of £300 to £350. And some clinics do offer a bit of a discount if you do multiple rounds of egg freezing and so on, but that gives you an idea of the order of magnitude of the costs. One thing we do offer that kind of helps, because especially if you're you're in your early career, or you're doing this to have a good option later in life, you typically don't have a lot of savings or lumps of cash sitting around. So we do offer credit finance through a partner agency, so it's interest free. So it allows you to spread that cost over 1 year, which can help with your cash flow. So rather than looking at £5,000 as a lump sum payment, you'd be looking at about £400 and a bit over monthly over 12 months. So it becomes a bit easier to sort of reach that goal or climb that hurdle. The next question that we have is what? Sorry, yes.
Sorry, can I add something
please.
to your statement? Because people who have some funding issues, and if they are young, less than 35 years of age, and they are not smokers and their body BMI is less than 30, they have an opportunity to take part in the egg share program. That is something we do in our clinics, don't we, Suvir? Yeah. So that is something people can consider. If they qualify for this egg sharing program, what I mean by that is when you are trying to freeze your eggs, you undergo ovarian stimulation. If somebody's ovarian reserve is very good, that means they have plenty of eggs and they are under 35, non-smoker, no inherited diseases, there are few things, and BMI should be less than 30. Under these circumstances, they can opt to donate 50% of their eggs during each stimulation to somebody who needs donor eggs. In return, they can do the egg freezing totally free of cost, and it also covers the medications, that is the hormones required. Like Suvir was saying, it's like 3,500 plus another 1,000, 4,500, all, and then screening tests are also free. So you don't spend that 5,000. Only thing you will have to pay for is the storage fees. So that will be 300 per year or 25 pounds per month that you will have to spend, but the whole treatment is free. But you might ask me one question there. Supposing somebody produces, say 20 eggs in a cycle, because if the ovarian reserve is good, one is likely to produce 20 eggs. That means you get to keep 10 eggs and you donate the 10 eggs. That means you will have to do another 2 cycles or something to collect 30 eggs. However, you can do again 3 times egg sharing. You don't have to pay second time or anything like that. If you are able to produce good number of eggs, and if you do not mind sharing your eggs, then you can take part in this egg share scheme, which will be helpful financially, and you are doing something positive to the community. There are a lot of people waiting for egg donors. We have a recipient waiting list.
No, thank you. That's a very good point. I forgot to mention the option of egg sharing. And like you said, you get to help someone out, which is, it's a really nice gesture. Okay, the next question we have, what age would eggs become poorer in quality, and I'm interpolating here, more damaged by the injection process? I'd like to hear your thoughts on this first, if you don't mind, Dr. Venkat.
So it is sort of a definite, it's not a definite cutoff like that. It is not an abrupt. So we usually say, look, the fertility declines over the age of 35. Then somebody asked me, you mean when I complete 35 at the stroke of midnight 12, then I become 36, or my eggs going to be poor quality? It doesn't happen like suddenly. So it's a gradual process. Actually, it starts when late 20s. After 30, they say that optimal time to conceive or have the good quality eggs is between 25 to 30. After that, then egg number goes down, egg quality starts going down very slowly. Whereas after 35, it's slightly, that curve is little deeper. That means it's more rapid. But over 38 is very rapid, and over 40, it's a steep fall. Then the quality, egg number, everything drops. So then that's why people, when you go to the clinics, fertility clinics, they will say, like, look, it is too late to use your eggs over the age of 43, 45, because a lot of people now like get married or settle down in life late after sort of stabilizing in their career and profession. When they do that, they don't realize they have sort of crossed that fertility optimal age, and that's why the egg quality will be worse over the age of 40. Before that, there will be a gradual decline. Having said this, it's not a general rule. For each woman, this can vary. And in families, some families, women go through early menopause, then they can have poor quality eggs at an earlier age. And also there is ethnic variations in the quality of the eggs and the number of eggs, and decline in fertility. So that there are so many factors which can cause, and the lifestyle factors affect. If somebody is a smoker, then the egg quality will go down even when you are 30. So there are other factors which can affect the quality. Age is the main factor, but there are additional factors which can make things better or make things worse. That we should remember as well.
Yeah, and I think it brings us back to the first point that we made, that we encourage women to get a checkup in their late 20s, ideally, and then we can keep an eye on the situation. At least we know what the picture looks like, and we review it regularly so that we catch anything before the situation becomes worse. And the last question is, how do you pick one good sperm? That's a very good question. So it's a bit crude, actually, or interestingly enough. So if you look at a sperm sample, most of the sperm is rubbish. There's only 4, the cutoff for what we call normal, so what the WHO classifies as a normal sperm sample is that it should have at least 4% of sperm be normal, i.e. with one head and one tail, which is astonishingly poor. That's why we use so much when we fertilize. So when we perform ICSI, we will look for a normal looking sperm, i.e. it's got one head and one leg, one tail, not one leg, one head and one tail, and it moves well. And that's what we're looking for, good, normal looking motile sperm. However, when we have concerns about the quality of the sperm, if the semen analysis, if some of the other sperm parameters don't look so great, or there's been some issues previously, the couple have had a miscarriage, or they've tried unsuccessfully with a round of treatment, Then there is another option, which is called IMSI, or it means morphologically selected, i.e. we're picking the best looking sperm. Now we use a much higher powered microscope in the lab to do this, and it allows us to pick the sperm cells that look the best, so they don't have vacuoles, i.e. these sort of dark clumps in the cell itself. So we can examine the sperm more closely, and we can then select the best looking sperm. Most of the time, that's not required, and if we have a good sperm sample, we can just select ones that look normal, so they have one head and one tail, and they move well. That's sufficient, and we'll get good fertilization. But if we are worried about the sperm quality, there are some other things, we have some other tricks up our sleeve that we can use in order to try and improve the chances of fertilization. Dr. Venkat, is there anything you want to add to that?
No, that is correct. I think you have covered all the relevant points for this question. Thank you.
Okay, so I think that brings us very nicely to almost the hour mark, and we have taken the questions. So I'd like to wrap up at this point, if I may. So we do, I can't repeat myself enough about this point to say we recommend patients or people to think about getting a fertility checkup, to monitor your fertility status, to know what's going on. Think about the future of egg freezing. Looks like a good option. It's something to consider because we think it's a great treatment option for women looking to preserve their fertility. Talk to us. We'll take all your questions. We're happy to help. We believe that in education and information is important. If you're a well-informed patient, you'll know what to expect. You know what your chances are. It's better for you and it's better for us. So please do talk to us. We're here to help. And then the last thing is our next webinar. So on the 22nd of March, about 6 o'clock on Tuesday, we're very sort of proud and honored to share with you a particular lady's journey to motherhood. She came to us after many miscarriages, and it's not a thriller, so I'm not letting the cat out of the bag, but we achieved a successful pregnancy after a very difficult journey, and she struggled with a lot. And we will be presenting a webinar on her story and how she became a mother. So it's very exciting, and I'm sure it'll be quite an emotional evening. And so all that remains is really to thank you, all of our audience. Thank you very much for attending. I hope it was a useful session. And Dr. Venkat, thank you very much for your time. And I'd like to thank our marketing manager, Delia, for organizing this. So thank you all, and have a very good night.
Thank you.